like with that link? Okay, okay.
Code 1 dialysis to MSU1. Code 1 dialysis to MSU1. Code 1 dialysis to MSU1.
This I'm not getting. This I'm unable to do. Okay, I'm unable to join few people. Can you? Hello. Yes. No, few people are trying to join, but I couldn't see here. I'm just getting the notification, but unable to add them. So more option. Okay, yeah, people is there that I've clicked actually. Okay. Okay. Yeah, yeah, I made it open. I think everyone can join now. Okay. Yes, okay. Hello, everyone. We're going to have a case presentation today on hepatosplenomegaly case by Dr. Sainath. We have moderators, Dr. Deep Vora and Dr. Neeren. Yeah, you can start, Dr. Sainath. Dr. Sainath, you are not audible. I think. Just unmute yourself.
Am I audible now, sir?
Yes, yes.
Yeah, yes, sir. So my voice and presentation is both are clear only, no, sir? No?
Yes, yes, it's clear now. You can start.
Okay. Distinguished moderators, organizers, a warm good evening to my fellow colleagues. Today, I'm gonna discuss about case of 50-year-old gentleman, Mr. AJ, who is a worker at fish market business at Dubai, currently hailing from Perindalmanna, Kozhikode, presented with complaints of exhaustion for past 12 months, loss of weight and decreased appetite for past 6 months, intermittent high-grade fever for past three months, and left upper quadrant pain for past 2 months. History of present illness. Patient was apparently normal 1 year ago. All the story started with the symptom of exhaustion, which was insidious in onset 1 year ago, progressive in nature. The exhaustion he typically described in the form of reduced capacity of doing business-related activities, which he previously used to do normally otherwise. However, there was no difficulty in initiating the activity. There was no decreased concentration or emotional stability, lack of interest, or lack of concentration or memory loss. There was a history of loss of appetite and weight loss for about 7 kgs, that is from 63 kgs to 55.5 kgs over a span of 6 months. There was a history of intermittent episodes of fever, which was insidious in onset, high grade, associated with rigors, chills, 2 episodes in the past 4 months lasting for about 2 to 3 days. He also noticed petechiae over the skin during the first episode of fever, which resolved spontaneously after 2 days. 1 month ago, the fever recurred, which was associated with running nose, throat pain, and it was treated symptomatically with amoxicillin clavulanic acid and antipyretics from local hospital. There was no history of evening rise of temperature, no night sweats. Fever was not associated with chest pain, breathlessness, or loose stools, or nausea, vomiting, headache, or altered sensorium. There was history of associated left upper quadrant pain for past 2 months, which was insidious in onset, non-progressive, and it is continuous, dragging in nature, non-radiating. Pain increased on deep inspiration and relieved on taking rest. He also noticed painless hard mass felt at the left upper quadrant pain because while holding the area because of pain for past 1 month. There was no history of cough, expectoration, breathlessness, or hemoptysis. No history of chest pain, palpitations, syncope, or swelling of limbs. There was no history of loose stools, constipation, melena, or hematochezia. There was no history of dysuria, hematuria, high-colored urine, anuria, or oliguria. There was no history of yellowish discoloration of skin or eyes or high-colored urine. No history of headache or altered sensorium or altered behavior. No history of blurring of vision, double vision, facial weakness, vertigo, tinnitus, or any other cranial nerve symptoms. No history of muscle weakness, muscle pain, or involuntary muscle movements. No history of paresthesias, dysesthesias, numbness, or any other sensory system involvement. No history of ulcers or joint pain or joint swelling. No history of bleeding gums, purpura, or hemarthrosis. No pet animals in the family. No history of recent travel except for travel from Dubai 4 months ago with these symptoms. Coming to past history, shall I proceed with past history, sir?
Yeah, continue.
Yeah. Coming to past history, there was no history of severe complaints in the past. No history of diabetes mellitus, hypertension, coronary artery disease, cerebrovascular disease, seizure disorder, or any thyroid abnormalities. There was no history of repeated blood transfusions in the past. There was a history of right inguinal hernia surgery 10 years ago, but there was no surgery-related complications at that time. Coming to family history, There was no history of similar complaints in the family members. He was born out of non-consanguineous marriage. Father was known diabetic since 60 years of age, and mother was a known hypertensive since 54 years of age. Both are not alive now. Personal history: he takes mixed diet. Appetite was decreased for past 4 months. Sleep was adequate. Bowel movements 1 to 2 times per day, which was normal in consistency. Bladder habits were normal and regular. There was a history of alcohol consumption once in a week for past 5 years, occasionally. No history suggestive of smoking. He was not on any medicines or no history of illicit drug abuse. To summarize, this is a story of 50-year-old gentleman who with no prior comorbidities, presented with progressive exhaustion, significant unintentional weight loss, loss of appetite, intermittent high-grade fever, rigors, chills, and petechiae, one episode of petechiae, and left-sided upper quadrant pain and swelling. So all these symptoms cannot be explained in one thing. So there are various differential diagnoses for this.
Yeah, we'll 1 minute. We'll go
Sure.
from. We'll just review it now.
Yes,
Okay. Just go to your first slide. No? Go from first. Okay.
Yes, sir.
Okay. So next one, the chief complaints. Okay. So exhaustion, you mean to say it was fatigue? You are saying, no?
Yes, sir. Fatigue.
Yeah, do you know any gradings of fatigue?
There was no grading of fatigue. Symptomatically, we can decide whether previously he could able to do the activity, whether he is doing it. I don't know. Not that I can remember.
Okay. No, basically we can use this. New York Heart Association is also applies to fatigue as well.
Okay, sir.
Okay, but it is on the cardiac condition, I'm saying. So
Yes, sir.
not
Yes,
for
sir.
all the cases. That's okay.
Okay, sir.
So you mean to say patient had fatigue for last 12 months and loss of weight. So what do you mean by loss of weight? You know, definition of the weight loss.
Over the past 3 months, there is 10% of, there should be a 10% of reduction in the patient's normal body weight. That is,
Yeah, okay. Fever. Then how do you grade fever? What are the types of fever? You know, like you said, intermittent. No, what do you mean by intermittent fever?
the fever is like 3 types: continuous, intermittent fever, and remittent fever. Intermittent fever means fever touches baseline, like normal temperature in between, whereas continuous fever, fever will be persisting all throughout the day and night. There is no decrease, or the reduction in temperature is less than 0.5 degrees centigrade. However, in intermittent fever, fever intermittently touches the baseline, whereas in remittent fever, fever continues to persist, but it will never touches the baseline. There will be ups and downs in the temperature, but overall temperature will be on a higher side.
Okay, so how do you differentiate this continuous intermittent? You're saying both remains high, never
Yes.
touches the base, both doesn't touch the baseline. No?
Baseline. The variation in temperature is more than 0.5 degrees centigrade, and it is remittent fever. Whereas variation temperature is less than 0.5 degrees centigrade, it is continuous fever.
Okay, so you're sure about it? 0.5? For sure, it's fine. As far as I remember, it used to be 1 degree Celsius. No?
Yes, sir.
If you have some difference, then it's fine. But
yes,
what I remember is that they used to say guidelines was more than 1 degree Celsius fluctuation is generally remittent versus continuous fever.
Yes, sir. I'll check it.
So based on these 4 symptoms, what do you think it can be?
I would like at this point of time, I would like to consider infective etiology, because he was along with the exhaustion, he was having high-grade fever, and which can be a loss of weight and decreased appetite can also be explained by tuberculosis. Sir, I would like to consider diseases like chronic diseases like tuberculosis in my first line diagnosis.
Other causes of fever which stays for this more than 3 months of fever, you know, almost 3 months.
And I would like another possibility is like inflammatory conditions or autoimmune conditions like
infections. I'm asking only about infection. Which infection persists for more than 3 months?
only
about infections.
like histoplasmos, like bacterial infections malaria can, it's not that persisting until 6 months. 3 to 4 months is may be present. Then another infections are like non-tuberculous mycobacterial infections. Then
So you're going through all rare. No? Tell about the common causes. No? Always tell about the common causes first, and then go to the uncommon. Then. TB, you said, as rightly said, TB
Yes.
is the one. Most India history wise, the first diagnostic differential should be tuberculosis. That's fine. Other than that, what can be there? Common diseases. Talk about
common tuberculosis. Then histoplasmosis is one thing which is also common. But
yeah,
Not so common in India.
how many cases have you seen histoplasmosis?
no, I have seen very few, sir. Very
Yeah.
few.
Endocarditis, infective endocarditis can present.
Infected endocarditis will present like this, but for progressing for about 1 year, this is one thing.
No, we are asking about more than 3 months of fever, no?
Yes,
Can
sir.
infective endocarditis have fever which lasts for a few months?
Yes, sir. Infected endocarditis is a possibility. So subacute infected endocarditis is one. Then chest pain.
So this patient had fever daily, had no?
No, sir. Intermittent. Only 2 episodes of fever, sir. It was like each episode lasted for only 2 days.
Okay, so in total 3 months, he only has 2 times he had
Yes.
fever.
Yes, sir. First episode 3 months back, and second episode 1 month back. First episode
So
was
then
associated
then can it be tuberculosis according to you?
No, sir. The symptoms are not likely of tuberculosis because it is a high-grade fever and associated with rigors and chills. And it is lasting for only 2 days, and there was no evening rise of temperature that he has mentioned. These things are not typical of tuberculosis. Only thing that we can consider tuberculosis in our DD is like through weight loss and loss of appetite. And one more thing is left upper quadrant pain may also have a like GI tuberculosis or anything can present with rarely presents with left upper quadrant pain. That's it.
Okay. So then based on this, I don't think that tuberculosis should be your first. When I ask you the diagnosis, you said tuberculosis.
Yes, sir.
So what else it can be? See, because your first symptom is fatigue, you're saying. No?
Yes,
first start is fatigue.
Yes,
so what
sir.
are the causes of fatigue?
Yeah, fatigue can be due to like any any infection can cause fatigue or any inflammatory conditions like any rheumatoid arthritis and sarcoidosis.
Just wait. Most common cause of fatigue?
Most common cause is anemia.
Anemia.
Yes, sir.
Correct.
Anemia.
Anemia.
So always talk about common causes. No? You're going through very rare causes starting only.
Yes, sir. Yes, sir. Anemia is the most common cause of fatigue.
So other causes? Just tell me 5 causes of fatigue. Common causes.
Like anemia. Anemia is one of the most common cause, and any infections. Infections is another cause of fatigue. Then certain inflammatory conditions can also cause fatigue, like arthritis, any underlying tumors or any this thing can cause malignant. Any underlying tumors or anything can cause fatigue. Then joint.
Yeah, that's fine. You've said basically one. But whatever you're saying, tell little fast only. Okay?
Yes, sir.
You have your exam now?
Yes, sir. Yes, sir.
Okay. So this month you have your exam. 30th is your exam.
Yes, sir. Yes, sir.
So while speaking, always if somebody asks you causes, just try to enlist it as fast as possible.
Okay.
Now you have tried to explain that this can be because of that, can be. Don't tell like that. Okay, can be, maybe because of that. It can also cause. So when somebody asks you causes, just tell, like, suppose this case is that fatigue.
Yes.
You say malignancy, inflammatory disorders, anemia.
Yes, sir.
So just tell causes like that. And if you don't know other causes, don't tell any wrong answers. Okay.
Okay, sir.
If somebody asks you 5, if you don't know 5, then it's fine. But
Okay.
just to Why don't answer the wrong answers?
Okay, sir. Okay.
So first you started with fatigue, then you said loss of weight. Since 6 months, he noticed the loss of weight.
Yes, sir. Almost.
What did
Yes.
you ask him about the loss of weight? Patient checked the weight, or did
Yes,
you
sir.
ask?
He told like previously while he went before going to Dubai, he went to Dubai at around 6 to 8 months back. At that time, when he went to Dubai, he checked the weight. While coming back, like 3 months back or something, when he came back, there was around 4 kg weight loss. And after that, when he first consulted at a hospital, it was like it was like 7 kgs weight loss from the weight he was previously seen at Dubai.
Okay. Suppose the patient didn't have a weight machine.
Yes, sir.
You want to find out about the weight loss. How will you find out from history?
There will be various signs like there is clothing will be like tight clothes may be becoming loose these days. There might be
Yes.
yes.
Okay. Yes.
Like
Yes, so Dr. Neeren, Dr. Deep, you
Yes.
want to ask anything on chief complaints?
Yeah, as I said yesterday,
Yes, sir. I'm just able to hear for now.
chief complaint should
So-
not. Sorry, go ahead, Dr. Neeren.
Yes. So I think his differentials are set broad at the same time. Infectious wise, it's okay.
yes, sir.
See, one close mimicker for TB other than histoplasmosis is brucella, especially in the southern states.
Yes, sir. Brucella is yes,
And I think, and one more to be kept, taking the history of Dubai exposure and these all, there can be, he had only 2 episodes of fever.
yes, sir.
So they
yes,
can
sir.
be acute.
Hmm.
And exhaustion, see, that is your main chief complaint as exhaustion.
Yes,
Why
sir.
did you keep it as a primary complaint?
He primarily came with the complaint of exhaustion only. This fever
Yeah,
and
but
all,
then I
he
think
like,
high grade fever you should not keep as chief complaint right now. Maybe you can mention it later on.
yes, sir.
Chief
Yes,
complaint. I understand that he's very tired. That is what he's
yes, sir. He wanted
coming
to
to tell
tell
you.
that he could
That
not
I'm
able to
feeling
deliver
very
in the
tired.
lab.
That's why I have come to you. So that is
Yes.
okay. Then high grade fever should not be a differential. I mean, chief complaint right now.
Yes, sir. Yes, sir.
Okay.
Yes, sir.
And that is also only 2 spikes of fever in 3 months. So maybe in 2 days, 1 or 2 days of fever spikes, I think. So
Yes.
I think that should not be a chief complaint. Okay.
Why I have kept is like there was a petechiae he has complained. There was like bleeding spots during the first episode of fever. Whether that is related or not, anyhow, I wanted to keep it in the chief complaints at this stage.
That's okay. Yeah.
Yes, sir.
But next, go to next slide. Any other questions? Otherwise, I have many questions. Next slide.
Yeah, that fever, na, you can suppose only 1 or 2 time it is there, na, fever.
Yes, sir.
Suppose you want to tell it, you can elaborate in present history of present illness rather than labeling it in chief complaints.
Yes, sir. Yes, sir.
It will be a better way to do that.
Okay, sir.
What is this? No difficulty in initiating activity, decreased concentration, emotional instability.
Yes, sir.
He is not depressed. That's what you are trying
Means
to say.
people will usually present them as fatigue only. So difficulty in initiating a activity, like initiating the daily activities, it might point out towards a disease like rheumatoid arthritis. There might be some emotional conditions associated with this, like which might, like depression, which may cause decreased concentration or apathy, or and there will be emotional instability. All these things may be psychiatric issues, lack of interest and all. They might cause exhaustion in this patient in a long run. So I have considered that it is not, I wanted to project it, it is not due to emotional or any functional involvement in this. That's why I wanted to tell you. That's it.
Akif, do you think this is required? I think that is too much digging.
Yeah, exactly. So actually, history of present illness, now whatever complaints you have given, try to correlate that. Like you have to tell about the progression of each disease, as you mentioned, insidious onset, progressive in nature. So in this fatigue also, you can describe like initially how. I mean, progressive means how he was in 1 year back, and now how he is now.
Now, initially he was like 1 year back. He used to do his job. He works as a worker at a fish business
So now,
area.
from this 1 year, how it has progressed?
Yes, sir. Like for past 1 year, it was before 1 year he could able to do the work until evening, and or he can even take overtime duties and all. But he used to get exhausted by afternoon by like past 6 months and all. And now it has progressed to such an extent that he could not able to do even 1 hour or 2 hours of job and all.
So I think mentioning that is better than other things. That the way you presented now, no, that is the way you are supposed to present. It should the other person should visualize this thing that previously was able to do this and now this is this much severe.
Yes.
In your previous history, it was not clear how much severe it is right now. Now
Yes.
that you said, it is clear. Okay.
Yes, sir. Yes, sir.
That is more important part. This negative history, I think you can avoid here, or just 1 or 2 words something, but
Yes.
not more than that. 2-3 lines is not required. Okay. Negative history should be bare minimum. Only important things. So I think it is okay. Next, your viva will be diverted unnecessarily here. Depression. What is the definition of depression? What is DSM-5 criteria for depression?
Yes, sir.
Anything can be asked later on. So just be careful about negative history. Next slide. So weight loss. Is this significant weight loss? You know the definition, so you said it right, so that is fine. Fever and petechiae. So yeah, you can mention it like this here in somewhere that he had an I would like to mention that he had 2 or 3 episodes of fever also in between with query petechiae, but whatever. So that way you can present it here. I think it is not required in the chief complaint. Now the negative history starts. So chest pain. Why chest pain? Breathlessness, loose stool. That is infection you are ruling out.
Yes,
Only
ruling out infection, sir.
Okay, next slide. Okay. Okay, next slide. This is not required. I am not going to details.
Yes, sir.
Much negative history is not at all required. Okay?
Yes, sir. Yes, sir.
Okay, actually, you can just finish it in one sentence, no? Rather than saying too many things. Mention too many things. Like each sentence, they can ask you questions.
Yes, sir. I mean, we were taught like to describe in the form of describe what are the things you are considering and what are ruling out. That's why I have projected, sir. It's okay. If I mean, I will really.
What you can do is in your case presentation, you're a DNB candidate. Or DNB candidate, no?
Yes, sir.
Okay,
DNB
so
candidate.
you can write a case sheet if you want, but while presenting, don't say it everything. Okay.
Yes,
so
sir.
they want, anyways, your case sheet will be taken by the examiner. You have to practice anyways without saying only.
Yes, sir. Yes.
Okay, so that you can mention, but just you can, what is most important, that only you can say. Like if you are considering any differential, like after taking the entire case, you must be aware of your diagnosis. No, you must be having 3 or 4 differential diagnoses.
Yes.
So relate particularly to that, any other history or any other major causes, if any is there, that only you can mention. Otherwise, all this thing is. So why headache and all you mentioned? You were suspecting any brain inflammation or anything? Why do you mention headache?
No, sir.
Okay, I think this many negative history is not required that I've felt. When Dr. Deep is trying to say the same thing.
Yes, sir. Yes, sir. Okay.
And what you said, no pet animals in the family. Okay.
Yes, sir. I want to rule out like.
Suppose a pet animal is there in your house. Which pet animal will lead to fatigue?
Brucellosis, like cattle in the in the house premises. Then even dogs and cats can cause like fever and fatigue.
Okay, so that's why I mentioned. Okay, fine. If you know the answer, then it's fine.
Yes,
will ask if anything you're mentioning. If you know the answer, then you say that's okay.
Yes, sir.
But if you're not confident about something, better not to write that part. Okay.
Okay, sir.
Yeah, go to the next. This blood transfusion. Why did you mention blood transfusion?
Because he was having progressive fatigue. Whether any previous history of any anemia, I wanted to rule out, sir.
Okay, fine. And I think this surgery, I don't think it's required.
Yes,
Is
sir.
it related to your case? No, no.
Not related to this case, but anyhow, I just mentioned.
Yeah, so actually one which is not related, no? Like just to finish the case, like the case presentation will give you so many topics will be there. All these headings will be generally there.
Yes, sir.
But just because it's there in textbook, it need not mean that in every case you should write that. So
Yes,
based on your case, what symptoms they have, based on that you have to choose what is actually required.
Yes, sir.
So this is not required. This line definitely it's not required actually. Okay.
Okay,
The
sir.
right invalid hernia surgery. Okay.
Yes, sir.
Right. Next slide. So even here also non-consanguineous, I don't think it's required. No? So which disease of consanguineous marriage will lead to fatigue?
No.
Do you know the answer?
No, sir.
Then you should not mention. No? It's not required also, not relevant only here. Okay.
Yes, sir. Okay.
And father was a diabetic. So anything with that related to that? If parents have a diabetic or hypertension,
He might be an unknown diabetic patient or a non-diabetic patient can cause fatigue and all symptoms.
Okay, so that's why you asked. Okay, no, if you have an answer, it's fine. That's why I said, no, if you have an answer, it's fine.
Yes, sir.
So Dr. Deep, Dr. Neeren, if you want to add anything.
Actually, I missed his differential diagnosis and summary.
No, sir. I have not. We
Can
didn't
just
go
repeat.
to differential diagnosis
No,
slide.
we didn't go. Okay. So it's just the history wise. I think so. Your main complaints were exhaustion, 2 episodes of fever. Other than that, anything significant that you can tell of?
Like weight loss and loss
Abdominal
of,
pain.
unintentional weight loss and loss of appetite. And left upper
So
quadrant.
regarding abdominal symptoms and important negative symptoms, what did you ask regarding abdominal symptoms?
There were whether is there any constipation or diarrhea? I have asked, sir. Any high? Is there any altered stool? I have asked. Stool color. Then if there is any dysuria or hematuria history, or then.
So see, it could be something like simple CLD.
Jaundice. Yeah. I have asked for this thing also. Jaundice. If there is any history of change in the color of the stool or.
Okay. So see, when your symptoms or the presenting symptoms or complaints are very less and vague, important clinical history pertaining to all the systems are important. But
Yes,
when they ask, you have to be ready with it. So keep it in mind. But when they don't ask, it's okay. You need not mention everything.
Yes, sir.
Okay. Because you are localizing. When you are localizing the system to abdomen, you have only one symptom to localize.
Yes, sir.
So you have to mention better symptoms regarding abdominal symptoms completely. Okay.
Yes, sir.
Okay. Next. That's all from my side. Anyone if you want to?
So here, this also no bowel movements. You can just mention bowel habits are normal and all. No? You not mention times per day, normal consistency. The normal means normal. Bowel and bladder habits are regular and normal is fine.
Okay, sir.
But it was decreased for past 4 months. Okay. Next you can.
Summary.
Okay. Now you tell me what are your differences based on this.
Based on this long-term history of fever, like a long-term history of fatigue, I'd like to consider infectious etiology like disseminated tuberculosis or histoplasmosis, even though unusual, malaria can present like 6 months history of fatigue and all. So I'd like to consider this thing. And neoplastic etiologies like myeloproliferative neoplasms, myelodysplastic syndromes, leukemias, lymphomas. Considering left upper quadrant pain, then carcinoma stomach or carcinoma, like any carcinoma tail of pancreas or rarely splenic malignancies can also present like this. And inflammatory conditions like sarcoidosis and infiltrative causes like amyloidosis then can also present. Then rarely there is a possibility of chronic liver disease with portal hypertension or then chronic hemolytic anemias, though it is no history of jaundice, I have considered in this diagnosis because there might be a during clinical examination there may be a chance of jaundice which may be found out. So I have considered abnormal hemoglobins also in this patient, and infiltrative disorders like Gaucher's disease which can happen at any age. So I have considered that thing also in my differential diagnosis. And rarely immunodeficiencies, very uncommon in this age, but acquired immunodeficiencies like HIV is one possibility at this stage.
Okay, so HIV is unlikely. Why do you feel so?
No, sir. Like there was no any high risk behavior, sir.
Yeah, but need not mean he must have not revealed you. But it's not really uncommon.
Yes, sir.
Patient can present with all the symptoms which you said.
Yes, sir.
Okay. And histoplasmosis, you kept okay. Is your case histoplasmosis? You are very fond of histoplasmosis in starting.
No, sir. Even only like coccidioidomycosis, it means Indian scenario, I would consider histoplasmosis is most common opportunistic fungal infection. That's the only thing.
Okay.
Coccidioidomycosis can cause, then even blastomycosis can cause fatigue and fever, weight loss.
See, all these you are telling about are specifically called as endemic mycosis because they are localized to a particular area only. So can you tell whatever you tell, where are they actually present?
Coccidioidomycosis and paracoccidioidomycosis are usually seen in Middle East, sir, as far as I remember, but I'm not sure, sir. I don't know.
They are in Northern America and Southern and Central America. Yeah. So they're nowhere in Africa. They are in the high temperatures. They will not exist.
Okay, sir.
Histoplasma still may be found.
Yes,
There are
sir.
other tularomycosis, penicillomycosis, but these are not found. Okay, in India.
Yes, sir.
Okay. So other differentials. So inflammatory causes, why are they possible or not? What are their usual symptoms that they present with?
Like amyloidosis, usually like they will present like renal symptoms, or more likely renal symptoms, or there is like this proteinuria, massive proteinuria is one thing they will present with. Then hyperproteinemia, bilateral pitting, pedal edema, and then they might present with ascites. Sometimes they might present with features of heart failure. Congestive cardiac failure is one of the thing. Then amyloidosis can also even present with the muscle pain, then fatigue. These are the things. Coming to sarcoidosis, is one of the presentation which presents like this, like an unintentional weight loss. There will be loss of appetite. Then there might be chance of hepatosplenomegaly in this patient.
Most common, what is the organ involved?
Lung is the organ that's most commonly involved.
Okay.
Breathlessness and hemoptysis.
Not hemoptysis, usually breathlessness, hilar lymphadenopathy and X-rays. That is how they usually present. Amyloidosis, you have mainly two types, secondary and primary. Primary, they can present with hepatosplenomegaly and dissolve. Second, and also important tongue swellings, macroglossia, and even petechiae that you tell. So these can be findings of primary amyloidosis. Secondary, as you told, they can have renal involvement and other ones.
Yes, sir.
Okay. Yeah.
Yes, sir.
So next, chronic hemolytic anemia. Is it possible or not at this age? And if possible, what type?
Thalassemia minor can go until adulthood, sir. One thing. and combined sickle cell with like a HBSC trait, and these can present. This can lead to like they are like minor presents like intermittent episodes of hemolysis in the childhood, and they can go until adulthood, sir.
Okay. So sickle cell, they would have been, some of this would have already been diagnosed at
Yes,
this age.
sickle cell, sir. Sorry, it is not sickle cell only. Pure sickle cell may not be sustained until this age, 60 years of age. A sickle cell thalassemia trait or sickle cell HBSC or like this combined hemoglobins can possible, sir.
So what is Ivan syndrome?
Ivan syndrome is like hemolytic anemia with thrombotic low hemolytic anemia along with low platelet count, sir. Thrombocytopenia, immune thrombocytopenias.
All hemolytic anemias?
Along immune hemolytic anemia, autoimmune hemolytic anemia with immune thrombocytopenias.
Okay. So I think that is definitely one possibility. But why do you put Gaucher's disease at this age as infiltrative disorder?
Like there are 3 types of Gaucher's disease. Type 3 Gaucher's can be present until adulthood also, sir. The usual sometimes they might present in the adulthood, and when we evaluate only we can find out. So very rarely. I have kept in the down in my list.
They would have been diagnosed. They would have been diagnosed, but they would have lived through this age.
Yes, sir.
It's not that now they will present.
No, sir. Infiltrative, I just kept it, sir. I won't consider, sir.
So immunodeficiencies, you said broadly. What are the possible immunodeficiencies that can present at this age?
No, sir. Acquired immunodeficiency was what I meant, sir. Not this congenital immunodeficiencies and all. I have not considered, sir. Acquired immunodeficiencies is possibilities like HIV.
Okay. So in neoplasms, hematological malignancies,
Yes.
you told about MDS, leukemias, lymphomas, MPNs. So can you briefly tell what will be the differences between these 4?
Myeloproliferative neoplasms usually presents with hepatosplenomegaly. Then whereas myelodysplastic syndromes also they will be in myeloproliferative neoplasms. Usually they'll present with features of hemo concentrations like headache, blurring of vision, and all. Blurring of vision, headache, then ringing sensation in the ears. These are actually features of hemo concentration. Whereas myelodysplastic syndrome usually presents with anemia, thrombocytopenia. In this situation, in this case, myelodysplastic syndrome is a possibility because he's complaining of fatigue, and they have a history of fatigue here. Then leukemias usually they will present with complaints of testicular atrophy. Then they'll have features of gum bleedings. Then they'll have features of altered sensorium in the form of CNS infiltrations. Then lymphomas usually they'll present with enlarged lymph nodes either in the cervical, inguinal, and other areas as well.
Yeah. Okay. So lymphadenopathy is one common feature with lymphomas.
Yes,
sometimes can be hepatosplenic lymphomas.
Yes.
Leukemias, so they are primary. They would be having initially low grade. They might develop into when blasts form in the tree. Okay, sir is here. Sir can explain. Sir, you want to continue?
So basically, mainly one thing was MDS. MDS does not have hepatosplenomegaly. As a norm, MDS does not have hepatosplenomegaly.
Okay, sir.
Myelodysplastic syndrome will have low HP, low platelet because of bone marrow function is not so well. There is no issue with hepatosplenomegaly. It will not be there.
Yes.
MPN definitely yes. Lymphoma. So there are lymphomas which will be either having lymphadenopathy with hepatosplenomegaly.
Yes.
There are lymphomas which can only present with hepatosplenomegaly. So that is fine. Leukemias also, there are some chronic leukemias, some leukemias which can present like splenomegaly with anemia and all these things. So that's okay. Just MDS should not be in the list. Okay. That's
Okay,
fine.
sir. Okay, sir.
I still, I mean, frankly speaking, I still think we are discussing a bit more in details. And our Viva should, if it goes to this level, it is definitely good for the student. Mostly it should roam around fatigue. What are the causes of fatigue, anemia? What are the causes of splenomegaly with anemia? What are the causes of what other symptoms were there? Weight loss, anemia with splenomegaly. What are the causes like that for each? And so whenever, if at all you get 5 minutes extra before your presentation, you
Yes,
just
sir.
make sure that whatever symptoms, chief complaints you are having in different combinations,
Yes,
what are the most common causes you are going to say for those symptoms in different combinations. Just try to remember that, because that is, and then why it is that or why it is not that, that much you should be able to uh, describe. I
yes,
think HIV should be a differential here, definitely,
yes, sir.
because especially having the all the symptoms, some, I mean, can be explained by that also. So okay, fine. I think the case is difficult because symptoms are very vague.
Yes,
So
sir.
that's why you are having this problem that there are too much differentials.
Yes,
But
sir.
okay, fine.
Yes. Shall I proceed with the examination, sir?
Yes, I think go ahead. Anything else? And
Nothing, sir. Yes.
yeah, go ahead.
Coming to general physical examination, he was conscious, oriented to time, place, and person, febrile at the time of examination. Height was 166 centimeters, weight was 55 kgs, BMI comes around 20.3 kg per meter square. There was pallor of skin and mucous membrane, significant pallor of skin and mucous membrane was present. However, there was no icterus, no clubbing, no cyanosis, lymphadenopathy, or beadle edema. Pulse was around 94 per minute, regular, normal volume and character. Condition of SL wall was normal, no radiofemoral or radial delay, and it was non-collapsing pulse. Blood pressure 130 or 70 millimeters of mercury in right arm in standing position. There was no postural drop in BP noted. Respiratory rate 18 per minute, abdominothoracic. Saturation is 98% in room air. There was no oral thrush or tonsils were oral examination of oral cavity. No tonsils was also normal. There's no rashes, petechiae, purpura, or no tattoo marks noted. There's no subcutaneous nodules, no thickening of the skin or dry skin, no signs of liver cell failure, no evidence of generalized muscle wasting or any other signs of malnutrition. Coming to systemic examination, inspection, shape of abdomen was flat, umbilicus was inverted and circular. There was fullness noted on inspection in the left hypochondrium. All the quadrants of abdomen moves equally with the respiration. There were previous inguinal hernia scar was present, and there was no engorged veins or visible pulsations or abdominal any striae. Coming to palpation, superficial palpation, it was non-tender, no guarding or rigidity or local rise of temperature. The liver was palpable 4 centimeters below the right costal margin. Edge was sharp and surface was normal. Spleen was palpable until 2 centimeters towards above and left side of the umbilicus, and surface was smooth. There was splenic notch was present. Palpation of kidneys, urinary bladder was normal. Abdominal girth was also normal. There was visible fullness in the left hypochondrium as it is seen here. Coming to percussion, upper border of liver palpable at 5th intercostal space in the mid-clavicular line and 7th intercostal space in the mid-axillary line. Liver span was around 14 centimeters. Spleen enlarged until 2 centimeters just above the umbilicus towards left side. There was no evidence of any ascites. Auscultation, the bowel sounds was normal, no audible bruit. Hepatic, there was no audible hepatic or splenic rubs. There's no venous hum. Examination of groin was normal, no femoral or inguinal hernia. External genitalia were normal. Examination of rectum and anal canal, was also normal. No fissures or skin tags or prolapse or fistula. Rectal examination was also normal. Prostate on rectal examination, prostate was also normal. Coming to other system examinations, cardiovascular system, first heart sound and second heart sound were normal, no murmur heard. Respiratory system, bilateral normal vesicular breath sounds heard. Nervous system examination, no focal neurological deficits, or fundus examination was normal.
Tell us, what is your summary of your case?
There was pallor of the skin and mucous membranes. Then there was
again, summary. You start with 58-year gentleman presented with only important things, and then on examination, these were the findings. That's it.
Yes, sir. This is a 50-year-old gentleman who presented with progressive fatigue for past 1 year, followed by intermittent episodes of unintentional weight loss and loss of appetite, then left upper quadrant pain and intermittent fever with 1 episode of petechiae. On examination, there was pallor of skin and mucous membranes, mild hepatomegaly with liver span of 14 centimeters and moderate splenomegaly. That's it. So with this.
So what are your differential diagnoses for mild to moderate hepatosplenomegaly?
So at this point of time, after examination, I can say malignancy is one of the things which is first in my list, sir.
Okay.
Either it, most possibly hematological malignancy, sir.
Okay.
Then another things which can be possible are like inflammatory conditions like inflammatory conditions like sarcoidosis, which can present with hepatosplenomegaly, and even when petechiae was previous history of petechiae was also there, so I can consider even amyloidosis as one of my differential diagnosis. In infections like disseminated tuberculosis can also possible at this stage.
Okay. Which hematological malignancies you are saying?
Myeloproliferative neoplasms, like
myeloproliferative neoplasm
is because he presented with fatigue and hepatosplenomegaly.
Yeah, you are right. Myeloproliferative neoplasm. Which myeloproliferative neoplasm?
Chronic myeloid leukemia is one thing, sir. Even myelofibrosis also presents with anemia and
right.
Yes, sir.
Right.
Most likely myelofibrosis, sir, because he in myelofibrosis only there will be anemia and thrombocytopenia, which is possible as in this case.
Both will have anemia. Yeah, so there will be thrombocytosis in CML,
yes,
and decreased platelet in myelofibrosis. So
yes,
that way that's okay. But petechiae was once only and for 1 or 2 days only.
Yes, sir.
So
Yes.
I think, and after that it is not there. So it is not that continuously there is low platelets. He has required multiple transfusions or multiple platelet transfusions persistently. So we don't know. So I think CML is much more common than primary myelofibrosis. So again, first should be CML only in your differential diagnosis.
Okay.
Other DD can be primary myelofibrosis. Okay. MDS already we discussed will not come here. Aplastic anemia will not come here. Aplastic anemia again usually does not have splenomegaly.
Yes.
So whenever you have low counts, low WBC, low HB, low platelet, anything, low counts.
Yes, sir.
You have two things. Either there is bone marrow which is not functioning well, or there is peripheral destruction. Whenever there is peripheral thing, there will be splenomegaly, hepatosplenomegaly more likely.
Yes, sir.
Or if the bone marrow is not functioning, then these things will not be there. Okay.
Yes, sir. Yes,
so MDS and even aplastic anemia, there is a bone marrow failure. So
yes, one possibility I have also considered is hypersplenism, sir, in this case.
Right. Because it will have a similar. So yeah, yes, okay.
Yes,
leukemia. Which leukemia? It's okay if you don't know. That's fine. Acute leukemias or chronic leukemias?
Chronic myeloid leukemia usually presents like this, sir.
Chronic myeloid leukemia, yeah, we discussed. That is actually MPN.
Yes.
Even though it's CML considered, it is MPN.
Yes, sir.
Chronic leukemia is basically like there is one called as chronic
Eosinophilic.
leukemia. Okay, I'll just tell you in 2 minutes. I just forgot the name.
Yes, sir.
There are one or two which are Harrison leukemia. Sorry. So
Here is it.
Harrison leukemia will present with splenomegaly, large spleen, splenic marginal zone lymphoma. So there are some lymphomas which will present in similar way.
Yes, sir.
Okay. So disseminated TB, yes, I would keep it as a differential diagnosis always. And sarcoidosis, because it is a differential diagnosis for tuberculosis. So that is also fine.
Yes,
So
sir.
I think that's okay. What you should say is I would like to examine, I mean, investigate further and decide what
Yes.
things I am dealing with. But these are my DDs.
Yes,
So
sir.
you have kept it broad. That is fine. That
Yes.
is good. And how will you approach this patient now?
Coming to approach,
Any other questions, Akif, Dr. Neeren?
Yes, sir. I think HIV still, which was
HIV,
been
yes,
there, I think
definitely.
should
Yes,
have been kept here as well.
yes, yes.
So, yeah. But otherwise, yeah, okay, still. But infective, as I said, only 2 episodes of fever, which can happen with anyone with any other diagnosis as well. So, no chronic, in multiple episodes of intermittent fevers as such. So, I think we should
Right.
see the other possibilities also. So,
Okay. Go ahead. How will you proceed?
so I'll proceed with hemogram first in complete blood counts.
No, I don't want to see the CBC.
Okay, sir.
Yeah.
Okay. I'll proceed with complete blood counts. I would check for any anemia or associated thrombocytopenia. I would like to also check how the WBC count will be and what is the differential count exactly. And then I would check for elevated ESR or any elevated CRP. Then urine routine examination, I would see any proteinuria or hematuria in this case. Then urine routine examination. After that, I would like to go for liver function test and renal function test in this case.
Okay. Show me the CBC. Go ahead with CBC.
Yes, sir. In complete blood count, hemoglobin was 7.8 gram per deciliter. It is normocytic anemia. Then total leukocyte count was 4,500 with neutrophils 50.2, lymphocytes 30%, and eosinophils 14%. Then platelet count was around 90,000. Urine routine examination was normal. There was no evidence of any proteinuria, hematuria, or any infection. The ESR was normal, CRP was normal. Renal function tests were also normal, except for mild hyponatremia. And then uric acid was elevated, 9.6 milligram per deciliter. So we have a liver function test showed a bilirubin of 1.33, and all other transaminases, alkaline phosphatase, and albumin were normal. Globulins was also 4.4. Lactate dehydrogenase levels were around 491, which was elevated, slightly elevated.
So what now? What does this tell you?
Elevated LDH means underlying.
Not LDH. This blood reports baseline blood
Yes,
test we have done. What does it tell you?
The picture shows bicytopenia, sir, and elevated uric acid.
Right.
And there is significant eosinophilia in the blood count, sir.
So how will you go ahead now?
I'd like to go for peripheral smear, sir. If there is any abnormal cells in the this thing in.
Yeah, you already said no. I would like to see different. Okay, go ahead.
Yeah. Coming to peripheral smear, red cell count was reduced, normocytic. There was polychromatophilic teardrop and nucleated RBCs were seen. Differential count in the peripheral smear showed neutrophils of 20%, lymphocytes 18%, eosinophils 8%, monocytes 1%. There were myelocytes and metamyelocytes around 5%, and platelet count was significantly reduced. So overall picture was leukoerythroblastic blood picture with normocytic anemia and eosinophilia and thrombocytopenias.
Right. I please hope that you don't get these reports in your exam. Okay. Then
Yes. I mean, walked up case, so that's why.
yeah.
Okay. So to characterize the exact liver and spleen and all uh, morphology, we have proceeded with the ultrasound abdomen, which showed liver span of around 14 centimeters, and spleen was also moderately enlarged, around 16 centimeters, and both the liver and spleen have normal echo textures. Chest X-ray was also normal. ECG showed normal sinus rhythm, and we have also wanted to ruled out before going to bone marrow biopsy. We need to rule out. We wanted to rule out ANA, IF, and ANA profile, which were all negative. ANCA profile was also negative. C-ANCA, P-ANCA were negative. So we have proceeded with bone marrow aspiration and refined biopsy after obtaining informed consent.
Yeah.
So bone marrow was suggestive hypocellular.
So what does leukoerythroblastic picture in peripheral blood tell you?
Yes, sir.
What does it tell you?
There are significant blast cells in the peripheral smear, which indicates marrow is hyperproliferative in nature, and
The problem is in marrow. Leukoerythroplastic picture in peripheral blood tells you that the problem is in marrow mainly, and hepatosplenomegaly is because of that problem that is most probably there. Okay, so that's why whenever you see leukoerythroplastic picture in peripheral blood, what will be your next step? You go ahead with bone marrow.
Bone marrow.
Okay, you go to see what is there. So now bone marrow, tell us what was there in bone marrow.
Hypercellular marrow, sir.
Yeah.
Sorry, hypocellular marrow. My mistake, sir.
Okay.
There was narrowed marrow spaces showing diluted sinusoids, fibrosis, and streaming of cells. There was suppressed erythroid series, normal myeloid maturation, and dysmorphic megakaryocytes seen in tight clusters. In this background, we can they have given a diagnosis of primary myelofibrosis with osteomyelosclerosis.
Okay.
So we have done for MPN reflex, sir.
So what are the causes of anemia with thrombocytopenia? Bicytopenia only, no WBC count less. There is WBC counts are normal, right?
Yes, sir. Yes, sir.
What are the causes of anemia with thrombocytopenia? See, any kind of such questions can come. That is the only. That is what I'm trying to ask you. You should be ready with all these combinations. Only WBC high, only WBC low,
Yes,
anemia with thrombocytopenia, alone thrombocytopenia, alone anemia. All these things, 3, 4, 5 DDs should be at the tip of your tongue. Okay.
Yes,
What are the causes of anemia with hepatosplenomegaly? What are the causes of lymphadenopathy with hepatosplenomegaly? What are the causes of gross splenomegaly? Okay, only gross splenomegaly.
Yes,
Okay,
yes,
all these questions are more important than discussing about this case, which is primary myelofibrosis right now. Okay,
yes,
so for you, for passing the exam, in a case of hepatosplenomegaly, differential diagnosis will be the key point. How will you, for each and everything, you should know 3 or 4 or 5 differential diagnosis. Okay.
Yes, sir.
Yeah. Okay, so it's primary myelofibrosis. Good that you have done MPN panel, JAK2 positive. I don't think it's required at this level that all these things you know, KLR negative, JAK2 positive, but it's good that it's already there. So, MDS panel was also done, but again, MDS usually does not have
hepatosplenomegaly.
Okay, if a MDS diagnosis patient comes with splenomegaly, there is something called as MDS MPN overlap syndrome. So should be kept in mind instead of still keeping it as MDS with hepatosplenomegaly. Okay. Presence of spleen in MDS is you should try to think that it is more than MDS. Something more is there.
Some associated condition along with MDS.
Something else is also going there. Yes. Okay.
Yes, sir.
So okay, JAK2 positive. More likely and more common is CML. So whatever you know about CML, tell me. Then I'll give you some more information only. I'm not going to ask. I am not expecting you to know a lot about CML. So whatever you know, you tell me. Then I'll give you some basic information about CML.
myeloproliferative neoplasm secondary to balanced translocation between BCR ABL in chromosome
Right.
9 and 22. It is
Right.
called as Philadelphia chromosome. Chromosome number 22, which is shortened, is called as Philadelphia chromosome exactly.
Okay.
So they have upon this
How do they
translocation
present?
happens, after this, sir.
How do they present CML?
They presents with usually with this all the cell lines counts will be elevated, like hemoglobin will be elevated, then WBC count will be elevated and platelet count elevated. It due to the activation of tyrosine kinase activities.
Yeah, HB will not be elevated. WBC will be elevated. Platelet will be elevated.
Yes, sir.
HB will be on the normal to lower range. Okay.
Okay, sir.
Yeah. Then there will be hepatosplenomegaly. They will come with usually that only early satiety and all these symptoms. So the splenomegaly symptoms, no, they will come with that only.
Yes, sir.
You will do a bone marrow. You will find out that there is a. How do you check for BCR-ABL gene fusion? What are the tests?
Yeah, fish fluorescent in situ hybridization technique.
Yes. There is NGS also. There is fish also. Usually it is easily detectable by fish.
Yes, sir.
Most common investigation is fish. Can
Fish.
you do it on the blood? Or do you always require?
We can do it in the blood,
Bone
sir.
marrow.
It can be present in any place.
Yeah. NGS you can do on blood basically. Basically, PCR you can do on blood, not fish. For
Yes.
fish, you need metaphase.
Yes.
For metaphase, you need dividing cells in the peripheral blood. Usually, these cells will not be actively dividing in peripheral blood. So, finding a metaphase in peripheral blood for this will be difficult. But you
Yes.
have to, what you can find is these cells will have DNA definitely. So you can find this mutation by fusion by polymerase chain reaction, that is PCR. So
Yes.
you can check on PCR on peripheral blood also, where you can find this BCR-ABL gene fusion, and then it is like similar. I mean, same way the way fish works. So PCR can be done on peripheral blood. Fish usually cannot be done on peripheral blood.
Yes, sir.
Okay,
Yes, sir.
in CML. And what are the treatment options you know about CML?
Tyrosine kinase inhibitors is a treatment like imatinib, dasatinib, nilotinib, then ponatinib is recently came drug, sir.
Right.
That is for tyrosine kinase. Resistant case of tyrosine, the resistant case of chronic myeloid leukemia will use ponatinib, sir.
Right. Okay. I think I think that much knowledge is enough. So that's fine. Imatinib is the most commonly used drug. We have the highest level of experience of using imatinib. It is one of the least, so the drug with least side effects. Only some myalgia, some weight gain.
Yes.
So there are no major side effects of imatinib, and majority of patients can take it over years, for many years. So I think are you supposed to know how will you follow up these patients and all these things? If you know, then you can tell us. Otherwise, it's okay.
Follow-up of this case.
That's okay. I think. Yeah, I think it's not required. So I think that is fine. What you should concentrate based on this case presentation is all your DDs, your history.
Yes.
Keep it to simple things. Fatigue, the causes of fatigue, causes of splenomegaly. So early satiety was there in your history, or it was not there?
Which thing, sir?
Early satiety.
Early satiety was there, sir.
Loss of appetite was. What is the difference between loss of appetite and early satiety?
Early satiety, loss of appetite is as a part of anorexia. I mean, it's a
Patient doesn't have a desire to eat.
Yes, sir.
While early satiety means patient wants to eat, he starts eating, and within half a chapati or one chapati, he will feel that his stomach is full now.
Full.
That is early satiety. There is no loss of appetite with early satiety. And usually, what CML or these patients, I mean, will have, if because of splenomegaly, they will have early satiety and not loss of appetite.
Oh,
Okay,
okay,
so
sir.
that is one thing. Or I think, yeah, so those things you should keep in mind. Keep all the DDs in your mind,
Yes, sir.
because hepatosplenomegaly is all about DDs. That's
Yes,
it.
yes, sir.
Once diagnosis is there, I think as a MD level, whatever you knew, I think those are enough things. You
Yes,
some more things are some basic side effects of all these drugs you should know.
yes, sir.
Nilotinib and dasatinib and all this, some basic side effects.
Yes, sir.
But other than that, deep knowledge is, I think, not required. If you reach to that level, I think you have already done well. So
Yes,
that is also fine. Okay.
yes, sir.
Uh, Things that are not common, things that you have not seen, and things which you don't know, you should avoid saying.
Okay.
So if you say something, just for example, you say histoplasmosis and then you don't know much things about histoplasma, and
Mm.
if the consultant catches you on that, then you will be stuck.
Yes,
Okay,
sir.
so keep it to things that you already know, you have seen. That is what they want to hear from you. That 80-90% of cases which will be like this only, how will you manage those 10% of rarer cases, if you know or don't know, doesn't make much major difference, but
Yes,
you should be able to do justice to those 80 to 90% common causes of all those differential diagnoses. Okay,
yes, sir.
so that much, that is what you are supposed to know.
Yes,
And examination and things were okay, so I think that's fine. This
yes,
case was a bit difficult, so that's why there were some ups and downs, but I think otherwise you did well.
yes, sir.
Okay.
Thank you, sir.
Akif, Dr. Neeren, anything?
Yes, so just so since I'm more interested in people with fever, just looking at after the things, just wanted to add one thing on the differential. I know it's important in some of the cases, especially you see ICU cases as well. Suppose this patient is having continuous fevers,
Yes, sir.
having all the examination findings that you told of hepatosplenomegaly,
Ah,
having biocytopenia.
yes, sir.
Can you think of any other conditions other than what you have told? Non-infective.
Non-infective.
Suppose not regarding the peripheral smear. I'll tell you peripheral smear findings will be bicytopenias. You will not have a leukoerythroblastic picture.
Yes, sir.
Okay, it will be decreased. It will have only cytopenias. I'll help you with the bone marrow as well. So bone marrow, you will have something called hemophagocytes. So what
HLH.
are, yeah. So
Yes,
that is, I thought that also, if the patient had fevers, other than that, everything was also fitting into it.
yes,
Okay.
sir.
Yeah.
I mean, like when we have evaluated, we have ruled out HLH also. So triglycerides and everything, every other investigation we have not mentioned. So that's it.
Okay.
Yes, sir.
Infective wise, I don't think you will have much differentials here. But for moderate splenomegaly, what are the other causes, like other than hematological?
Mm, uh,
You also told once malaria can present in this way.
yes,
So
sir.
why does it present, and what will be the diagnosis to identify chronic malaria?
A rapid diagnostic test for malarial parasite, but then peripheral smear.
So, yeah, what is tropical splenomegaly?
Uh, in chronic malaria patients, there will be like autoimmune reaction. I'll take it out, sir.
Uh,
I
so
know, but I cannot able to express it. Yes, sir.
you need not have active malaria. You can only have persistent antibodies to malaria, and
Malaria,
that can
immune
lead to
process.
splenomegaly as well. So that is mostly seen in tropical region. That's why given the name tropical splenomegaly.
Yes, sir.
Okay. So, you need not, your antigens all can be negative. Only
Yes,
by serology, actually, you will be able to diagnose them.
yes, sir.
Yeah, fine. Otherwise, infective wise, I think this is more than enough.
Yeah, I think any questions from anybody? Okay, so I think we can just end the session here. You did well. It was a difficult case, I understand.
Yes, sir.
You did well, but just focus on that history part. Okay, don't mention all the thing which is there in the book.
Yes,
The
sir.
negative history part, I'm saying.
Yes, sir.
Okay. Okay, then I think we can end here. It was a good presentation. Thank you, everybody.
Okay, sir.